Hello, this is Brittany Moore. Today is November 4th, 2025, and I am recording my chest, lung, and thorax video for MSN 572. I'm going to get started. Here is my computer, my ears, and a room scan. Here's the floor, the ceiling, and that. I do have a couple of supplies. They're over here on this counter. I have my little tape measure and a pen to mark when I do my measurement of the diaphragmatic excursion, and I will get started now. So I'm cleaning my hands with hand sanitizer before I enter the patient's room. Hello, my name is Brittany Moore. I'm a family nurse practitioner student from United States University. How are you today?
I'm doing well.
Good. Can I start with your initials and your birthday?
DM 7482.
Awesome. And how old are you?
42.
Great. So just before we get started, I have to let you know that I'll be recording a video of this assessment and uploading it to YouTube as unlisted for my professors to view and grade. Can I get your consent to do so?
Yes.
Thank you. Okay, so the first thing that I'm going to do is I'm going to start my assessment with inspection. So I'm inspecting the front of your chest, so the anterior and the posterior of your chest. And I'm noticing that there's no deformities and there's no abnormalities. There is no pectus excavatum or pectus carinatum or any barrel chest. As I'm looking at the anterior posterior transverse ratio is 1:2, which is a normal finding. The next thing that I'm doing is I'm assessing the respiratory rate and the respiratory effort. So the respiratory rate for the purpose of this video is 16. I'm not noticing any shortness of breath, no work of breathing, and the respiratory rate is regular and the depth is normal. There's no abnormal rhythms like Casimoles or chain strokes. I'm not seeing any diaphragmatic breathing. I'm not seeing any retractions, and there is no accessory muscle use, so the work of breathing is regular. The next thing that I am doing is I am assessing the color of the skin. The color of the patient's skin is normal for ethnicity. I'm not seeing any cyanosis around the mouth. I'm not seeing any cyanosis with the fingers or in the toes. And then I'm also not seeing any clubbing, which would indicate a pulmonary disease. It could indicate something like COPD or cystic fibrosis. Next thing I'm going to do is I'm going to palpate. The first thing I'm going to palpate for is for tactile fremitus. The tactile fremitus is a test that tests for the vibration. So when you talk, you have vibrations that come through the lungs to the top of your skin that you can feel. And so I'm going to perform this with the ulnar aspect of my hand. And then every time I move my hands, I'm going to have you say 99. Okay? So
99, 99, 99, 99, 99, 99, 99.
Great. Okay, so anterior, I'm not noticing any unilateral decrease or increase in the tactile fremitus. It is symmetric and equal. So I'm going to move to the posterior. So I'm just going to turn this stool a little bit. There we go. I'm going to do the same thing posteriorly, okay?
Okay.
So ready?
Yes.
Okay.
99, 99, 99, 99, 99, 99.
Great. And then on the posterior, again, I'm feeling the symmetric tactile fremitus. There's no unilateral increase or decrease of that fremitus or that vibration. The next thing that I'm going to do is I am going to test the respiratory excursion. So what I'm going to do here is I'm going to place my hands on, I'm going to do it front and back, so anterior, posterior, and I'm going to place my hands on around your diaphragm, so around the level of the 10th rib, and I'm just looking to see the expansion of the chest, and I'm looking for symmetry there. So I'm going to start here, so in this costal margin, and then I'm just pushing it together a little bit so that way I can watch my thumbs move apart. So go ahead and take a big deep breath in and out. And so that shows me the range and symmetry of the chest expansion. It also shows me my thumbs were moving out in a symmetric fashion, and that's a normal finding. I'm going to do it on the back side also, so we'll do this posteriorly. And the same thing, so the level of the 10th rib. And go ahead and take a deep breath in and out. Great. And that was the same finding posteriorly. I'm going to turn around. I was noticing that I had symmetric movement of my hands with the chest expansion and contraction. The next thing that I'm going to do is I'm going to palpate for costal chondral tenderness, and this tests for costal chondritis. So if you have any pain as I do this, let me know. Any pain? Okay. And so that's negative for costal chondritis. That's an inflammation of the connective tissue and the joint of the ribs to the sternum, and that's a normal finding to not have that. The next thing I'm going to do is I'm going to palpate, or excuse me, I'm going to percuss. So I'm going to start percussing anteriorly and posterior. I'm going to start up here, and the way I'm going to percuss is I'm going to use my non-dominant hand, which is my left hand, and I'm going to just use my third digit or my middle finger as the finger touching the patient. And then I'm going to strike with my dominant hand, my third digit, which is my middle finger, just a quick strike. And I'm expecting to hear resonance. And I'm going to follow a ladder pattern. Okay, and I heard resonance as I percussed through the anterior chest wall. And now I'm going to do the same to the posterior, so we'll go ahead and just turn halfway like that. Again, following that same ladder pattern. You can actually put your hands up like this, kind of cross them on the shoulders. It opens up a little bit more. Oops, start again. Okay, and then as I percussed the posterior, again, I only heard a resonance in the posterior lung fields as well, and that's a normal finding. The next thing I'm going to do is I'm going to measure the diaphragmatic excursion on inhalation and exhalation. And so the way I'm going to do this is I am going to measure the level of the diaphragm on inspiration and expiration. So what I'm going to have you do is I'm going to have you take a deep breath in, exhale completely, and hold it. And then I'm going to tap on your back or percuss on your back until I hear it change from resonant to dullness, and I'm going to mark that. Okay? And then we'll do a second test after that. Okay?
Okay.
So tell me when you're ready.
Ready.
Okay, go ahead. Okay. Okay. And then I'm not going to mark on your shirt, but I'm just going to make a little indentation. Okay, if I was in clinic, I would have the patient dressed a little different, but for privacy purposes, we're just leaving the clothes on for this video and this assessment. And in clinic, I would actually do this on both sides. I'm just going to do it on the one side for the purpose of this video. Okay, and then what I'm going to have you do now is I'm going to have you take a deep breath in and hold it, hold the in until I'm done. I'm going to do the same thing. And then I'm going to measure it, okay? And I do have a good little mark in your shirt, but that won't ruin your shirt, okay? So tell me when you're ready.
Ready.
Okay, go ahead. Okay. And go ahead, you can let it out. Perfect. I hope I didn't leave the field, okay. Now, with centimeters, we're going to measure this. And that is 4 centimeters, which is a normal finding. Anything between 3.5 and 5 is considered within normal limits. So, the next thing I'm going to do is I'm going to auscultate anterior and posterior. So when I do this, every time I put my stethoscope down, I just want you to breathe in and then out. So just a quick, we'll make it quick so hopefully you don't get lightheaded, okay? And again, I'm going to follow a ladder pattern. I'm starting in the apices of the lungs, okay? One more. Good. Okay. So I listed in all of your lung fields and then also medial as well. So I only heard resonant sounds as I was auscultating. I only heard vesicular sounds as I was auscultating. Vesicular sounds in the lower portion of the lungs and then bronchovesicular in the upper portion of the lungs, which is a normal finding. There were no adventitious breath sounds, no wheezes, no crackles, and no stridor, no rhonchi. And that's all would be irregular. The normal breath sounds is a normal finding. So I'm going to have you go ahead and turn, and we'll do one more auscultation and then a test, and then we're done. Okay, so same thing. I'm going to start up here. Over here. Good job. Okay. Again, posteriorly auscultating, I only heard normal breath sounds, no adventitious breath sounds, just those vesicular and bronchovesicular breath sounds that are within normal limits. So the last thing that I'm going to do is a special test. It's called bronchophony. And what it tests for is like pneumonias or consolidations in the lungs. And if this is positive, it could mean that you have some consolidations or some pneumonias in your lungs, which would be an abnormal finding. But what I'm going to do is I'm going to place my stethoscope down in those same areas that I was just auscultating, but every time I put my stethoscope down, I want you to say 99, okay?
Okay.
And what I'm hoping for is the expected finding is that it's going to be muffled. If it's clear, then that's a positive sign, and we don't want that.
99, 99, 99, 99.
Let me start again, sorry.
99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
Great. Okay. And so I only heard muffled sounds. I did not hear any clear 99, so that is a normal finding. And so that would be a negative test for the bronchophony, which means that there's no consolidations. The consolidations make it so that the sound can travel easier through the lungs and then can be heard. So that is my assessment. Thank you.